involved with RSN for nearly 15 years. Support from someone who's been there makes all the difference.
Hey David, what are you listening to?
Kidney Talk, an online radio podcast that talks about kidney disease and the prevention of it.
Oh cool, where can I find that?
Oh, you can download it on iHeartRadio, Google Play, and Apple Podcasts.
Oh nice, I'll definitely have to download that.
Shout out to Renal Support Network, the annual Renal Support Network essay contest. I won the Renal Support Network contest last year, the Warrior, and we are all warriors. So thank you. Keep on doing all that you do, and be happy and healthy and keep the hope. Thank you, Renal Support Network. Woohoo!
As a kidney transplant recipient, I find that having an actual publication like Kidney Talk is an invaluable resource for any kidney warrior at any stage.
RSN keeps me informed of kidney advocacy issues so my voice can be heard.
I'm really looking forward to the prom this year and meeting people who are just like me. Dressing up is super fun and all the activities are amazing. Can't wait to see you there.
Hi, I've been participating in the Renal Support Network 30-minute fitness Zoom classes. Not only have I lost 15 pounds, but I can also strike a yoga pose like this.
When I created Renal Support Network back in 1993, I had no idea the impact that I would have among my peers. An illness is too demanding when you don't have hope, and peer support, education, and knowledge are crucial to our survival. We have a great week planned with some incredible speakers, great information for you to share, learn, so we can survive and thrive with this illness. It's imperative. So stay tuned. We're going to have a great event, and a shout out to our corporate mission partners for making this happen. Bring up our next speaker, and I just got to give a picture here of Rob Blaser. I've known Rob Blaser for probably 2 decades, and I like your little signs in the back. Go away, I'm reading. You discover you have wings when you open a book. And I don't know, you got a lot of favorite books there, Rob. Maybe in your presentation you can let us know a good book to read this weekend. But it's my pleasure to introduce Rob Blaser. He's the Director of Public Policy for the Renal Physicians Association. And we have another thing in common, that he likes diners, drive-ins, and dives. So we're always talking about food whenever we chit-chat. So thank you so much, Rob, about telling us a little bit about what to expect in the upcoming, based on the election. So you got a big job today.
Well, I hope to fulfill expectations here, Lori. Thank you. I don't know. Happy to be here. Thank you so much for the invitation. Is my slide deck up? Does that show up? Or
Suzette's going to bring your slide deck up right now.
Okay. So yeah, I know Lori for a long time. I think I spoke at one of your patient meetings in DC. That literally was probably 15 years ago. I think on a Sunday night, you guys were doing a Hill Day on a Monday maybe, and I think on a Sunday night we talked, maybe, I don't know. I don't remember, but anyway.
It's been a while.
Yep.
So Suzette, do you have the slide deck there?
Oh, there we go. Life is good. Zoom is amazing. All right, so there's the title slide. That's who I am, and you all know who you are. So we can move on to the next slide, please. So the way I generally structure these talks is I give a legislative overview, a regulatory overview, kind of an across the waterfront, what's going on in kidney disease. And then the last couple of slides will be a little bit more of an outlook, but this is, the slides are just sort of a jumping off point. So I'll kind of riff on what's here, and I'll try and go through these swiftly so we can leave some time for questions at the end. But I always think it's useful to talk about where we were a year ago, because I kind of give you some perspective on where we are now. Discuss the state of play in DC, what's going on here right now, and then a couple of the one bill that really has a good chance of passing before the end of the year, and another one that has a lesser shot but not impossible, and then some other kidney bills that are out there. Next slide, please. And then give a regulatory overview. Of course, the big deal in kidney over the last 18 months has been the Trump administration's Advancing American Kidney Health initiative. There's been some news on that in the last couple months, and it'll be interesting to see what the future holds for that as well. Of course, with the public health emergency, telehealth and Medicare has really blown up. We'll talk about that a little bit. Just one slide on the 2021 payment rules. For what it's worth, my day job is I'm the regulatory analyst, director of public policy for RPA, and I cut my teeth on Medicare physician fee schedule, how nephrologists get paid. So just one slide on that, and then talk about Medicare Advantage, although if I'm not mistaken, you've already had a presentation on Medicare Advantage. But this is just one slide and kind of our perspective on it. Next slide, please. So where were we a year ago? I find out I'm running out of ways to say that this administration is atypical, administration like no other, unorthodox administration. But really, again, atypical administration continues pursuit of traditional GOP goals, Republican goals such as deregulation, privatization of health programs. And this administration has done that as well, and was doing that as well a year ago. There were expectations of pre-election year legislating, but a year ago they were waning. Everyone was saying in 2019, you better get all your legislating done this year because you're not going to do it in an election year. So everyone was hoping to get big stuff passed a year ago. Oh. That didn't really happen. And part of that is, the impeachment process began last September. And that kind of had a chilling effect.
Cochran's going to come by in a minute. I forget what she's doing.
Okay. If folks want to mute themselves, that might be the best way to go. And then the acute kidney injury, like I said, acute kidney injury, the Advancing American Kidney Health Initiative was really big news in kidney care. But outside of AAKHI, why don't we go back a slide there? Outside of AAKHI, there wasn't much going on in Medicare. And as far as what AAKHI was doing, there's all kinds of rulemaking that has happened, and we'll have to see how, or there was a lot of rulemaking going on, and we'll have to see how all that plays out.
Hey,
now,
Rob, the AAKHI is can you just repeat what that acronym is?
Sure, it stands for the Advancing American Kidney Health Initiative, and I have a series of slides on this in a little bit, but this was the big momentous thing that the administration did, announced in July of 2019, and are trying to find ways to advance kidney care to, there we go, okay. They came up with payment models and other programs, ways of, developing wearable kidneys, for instance, activity on living organ donation, activity on organ procurement organizations. And that was huge news in kidney care a year ago, but the rest of HHS was kind of quiet. And, we were really excited when the kidney models came out, but then everyone started reading the fine print of the programs and people were less excited. So anyway, we can move on to the next slide. So what is the state of play in Washington right now? And I would say, in short, it's absolutely bonkers. We're in this, not only are we in this interregnum between the Trump administration and the Biden administration, but this has just been the craziest year you can imagine. Of course, there's COVID, racial strife, what went on with the elections, and unexpected results in a lot of ways. The fact that there was a vacancy on the Supreme Court really shot down any chance of meaningful legislating, although in fairness, they weren't really great to begin with. Everybody was celebrating the COVID relief packages in the spring, but it seems like that train is stalled. We'll see what happens in the next couple weeks. Immediately post-election, Senate Majority Leader Mitch McConnell sent some signals that he thought there would be another package, and he was ready to work with the Democrats and Nancy Pelosi in the House But lately, it seems as if both sides are saying that they still want what they want and don't want to compromise. So we'll see what happens with that. And then even if they were to compromise, then you got the issue of what would President Trump do? There's some talk that he's not going to be willing to be signing too many bills during the lame duck session. So it could be that Congress could get work done, and then there might be a problem with getting the bill signed. So, of course, the unpacking of the Biden victory and the Republican success in Congress and the implications of that is still happening. You know, a lot of people thought it would be a blue wave, and the blue wave did not occur. I think folks underestimated what would happen in the states. And so the Republicans had much more success in the Senate and House races than was expected. And then the increased focus from the Advancing American Kidney Health Initiative raises the profile of all kidney issues. But whether this really results in positive change or a bill getting enacted kind of remains to be seen. Next slide, please. And then the state of play on the regulatory side. You know, the administration, what they did with regard to telehealth and Medicare was stunning. Absolutely nothing but historic. They really did, you could say, 10 years worth of policy making in 6 weeks, 8 weeks, something like that. But we'll have to see what happens moving forward. Will they hold up? There are some roadblocks into telehealth lasting longer. The administration is rushing to advance and finalize regulatory initiatives across the board. And this would be for the ESRD treatment choices model in kidney disease care. There was an article in the New York Times about a month or so ago that the Trump administration was kind of reading the handwriting on the wall that their days might be numbered. So outside of medicine and, you know, across the whole panoply of the regulatory world in DC, they were rushing to get things finalized because they knew their time might be short. And of course, there have been huge changes in kidney care reimbursement, organ procurement, and financial support for organ donors. And these changes have either been proposed, revised, delayed, or finalized. And I'm going to talk about all of that in a few slides. So next slide, please. So as a reminder, and this is just kind of a level set for how policy happens, Congress enacts legislation but cannot implement it. The executive branch, the administration, is charged with implementation. And you know what happens with Congress is that sometimes they will write a very bare bones bill and leave everything to, say, the Secretary of HHS to figure out, or they will write more specific legislation. So it sort of depends on what comes out of Congress. You know, Congress does retain oversight power and may investigate how the executive branch has administered the programs or laws that Congress has approved. So Congress oversees the administration of Medicare and thus the ESRD program. And the agency that does that in DC and Baltimore is the Centers for Medicare and Medicaid Services. And it's important to remember that there's a difference between political appointees and career staff, or the deep state. Career staff is especially important at CMS, but there are also plenty of lifers on Capitol Hill. And one way that this will manifest itself in kidney disease over the next 6 months or so is the fact that the payment models, for instance, all came out of the Centers for Medicare and Medicaid Innovation, what some people call the Innovation Center at CMS. And most of those people are career staff. So, you know, would be the expectation would be that the kidney models would, you know, proceed the way they have either been proposed or finalized as they are now, but we'll see. But that's one reason to think that the kidney models aren't going to go away, because the career staff are the ones that wrote them and did everything with them. Now, there could be a decision from on high that says we want to freeze these for a while and take a different look, but it doesn't necessarily mean that's going to happen. And again, there's also plenty of lifers on Capitol Hill as well. People might bounce around jobs a little bit, but there's a lot of folks who spend their life doing legislative work on Capitol Hill. Next slide, please. So a big bill that we're watching right now, and this is the opportunity for a big victory in this Congress if all the roadblocks can be overcome. But the immunosuppressive drug coverage bill, that on the left is RPA's issue brief on the bill. The bill numbers there noted. It was introduced in the House just before Christmas last year and introduced in the Senate right before COVID hit in late February. The goal would be lifetime coverage for immunosuppressive drugs for kidney transplant patients. And we really have an unprecedented opportunity right now. This administration is absolutely all in on this bill and wants to get it passed. And what might be most important is that the immunosuppressive drug coverage bill is now considered a saver. So Congress could use that money that's saved by the enactment of the immunosuppressive drug coverage bill and pay for something else they want to do. And in my experience, once something's a saver, it's almost a done deal. There was a bill a couple of years ago for acute kidney injury in Medicare, and they covered it when it's provided on an outpatient basis in a dialysis facility. And as soon as we saw the scores indicated that it would save money, I was like, that's kind of game over. And it ended up getting passed about 3 months later. So in terms of co-sponsors, there's 107 in the House and 23 in the Senate. This is as of about 3 days ago. And these numbers blew up recently. I don't know, what happened in September and October, but they gained a lot of co-sponsors. So there's really intense all hands on deck advocacy going on right now for these to be included in what they call an extenders bill. There's a couple of health policy priorities like children's health care and community health centers that get passed every year, and they kind of what they call a must-do provision, and they do that through what they call an extenders bill. And the hope is that the immunosuppressive drug coverage bill will be attached to the extenders bill. Next slide, please. So the other bill I'm going to talk about that has a shot of happening this year, this is a longer shot than immunosuppressive drug coverage, but the Living Donor Protection Act, and you see the bill numbers there. Now, this got introduced right when this Congress started in February of 2019, recalling that Congresses last for 2 years. So this began right at the beginning of this current Congress, whatever that is, 20 months or so ago. And it addresses barriers to organ donation by prohibiting the denial of coverage or an increase in insurance premium for living organ donors. It designates organ donation surgery as a serious health condition for the purposes of the Family Medical Leave Act, and that's a big deal, and requires HHS to update educational materials. Now, the Department of Labor did issue what I believe was called an opinion letter saying that they were treating organ donation surgery as a serious health conditions for the purposes of the Family Medical Leave Act. But that is just an opinion letter. It's not law. So the idea is to get this enacted in law so it would remove all doubt, and it couldn't be that the next administration could undo that and issue a different opinion. So currently has 99 co-sponsors in the House and 24 in the Senate. I think traditionally the insurance industry has sort of been an opponent of this legislation. I think they'd be on the hook for more coverage for folks. My understanding is that they've been in contact with people in the kidney community, and their opposition might be being blunted a little bit. So maybe this has a chance, but we'll see. Next slide, please. So other kidney bills that are out there right now, and I'm going to begin with what's called the Lost Organ Act. And of course, in Medicare, everything's got to have an acronym, or Medicare in legislation, I should say, everything's got to have an acronym. And this is the Lost Opportunities to Supply Transplantable Organs. And it promotes better tracking and public reporting of lost organs by UNOS and others to minimize future loss. There were reports that organs were being donated and then getting lost in the process and wouldn't be able to be used. This is a bill that I think is more of a signal to the organ procurement and UNOS community to say you better do a better job of tracking your organs. I don't think anyone thinks this bill is going to get passed, but it sends a signal to those communities that we're watching you and you better do a better job. Excuse me. So the next bill I'll talk about is the Patient Access to ESRD New Innovative Devices Act. And this requires CMS, Medicare, to establish a process for making payment adjustments in the ESRD prospective payment system. That's what PPS stands for, payments for innovative devices. So this is the PPS is how dialysis facilities get paid, and it's virtually the only payment system in the Medicare payment realm that doesn't have some way of paying for innovation. And it's a real problem. And you hear people say that dialysis hasn't appreciably changed in 30 years. And this is a big reason for that. There's no way to pay for innovation. And so the investor community doesn't want to invest in stuff that would be innovative in ESRD because they know there's no way to get paid for it. And there's a lot of efforts to to change that. I can tell you that Kidney Care Partners, for instance, a coalition of groups, This is one of their biggest issues, and we're completely supportive of that as well. Again, this bill, the chances of it ever becoming actual law are not great, but it's a signal that's out there that says, this is something that has to happen there. So, and then finally, there's something called, and again, another great acronym, the BETTER Act, which stands for Bringing Enhanced Treatments and Therapies to ESRD Recipients. And this is the next generation of what was known as the ESRD Patients Act in the previous Congress. And what it does is it creates payment models for in-center dialysis care. And the purpose of the payment models is to promote coordinated care in kidney disease, bring coordinated care to places where it might not happen through the other payment models that have been proposed. Now, this has been a source of controversy in the kidney community over the years because there are a lot of people that perceive that this is just something that the big dialysis companies want to have happen. And there's concern about that. If I were to defend this, I would go back to what I said a moment ago, that there are a lot of parts in the country where coordinated care isn't happening. And the proponents of this bill would tell you, we're just trying to spread coordinated care as far and wide as possible and make sure that there's a payment model to make sure that that happens for in-center patients. So controversial. I don't think this bill is going to be, moving anytime soon, but that's what it's about. So, and again, final bullet, none of these bills are likely to progress, but it gives you an idea of what people are thinking about on the Hill. Next slide, please. Okay, so we're switching over to regulatory issues now, and I'm going to talk about the Advancing American Kidney Health Initiative in greater detail now. And first, the primary goals, and this was kind of the headline back in July of 2019 when the administration rolled this out, but the primary goals were to reduce the number of Americans developing ESRD by 25% by 2030, seeking to have 80% of new ESRD patients in 2025 either start at home or start with a transplant, double the number of organs available for transplant by 2030. And they would do this not only through promoting organ donation, but trying to figure out ways to promote the development of wearable kidneys and artificial kidneys, and see if that could happen as well. And then there were the payment models that I'm going to talk about in a lot more detail in the next couple slides. And then I have one slide on the organ procurement and living organ donor out of pocket proposed rules. And there's a question mark there, and I haven't checked the website in the last couple of days, but there's a government website that'll tell you where proposed rules are. And this was in the waiting to be released category for a long time, and they don't show up on the website anymore, but I don't think the rules have come out yet. So the final rules have come out yet, so we'll just have to see where those are. Next slide, please. So the first model I'm going to talk about is called the ESRD Treatment Choices Mandatory Payment Model. So if you see ETC, that's what this stands for. And so this is mandatory. So this is not too many mandatory payment models in Medicare. They've tried it a couple times with some drug products and with knee and joint replacement a couple of years ago. But generally, Medicare won't force providers into payment models. But they wanted to try and do it with this one because they thought they had to kind of do that to get people engaged. The final rule came out on September 18th. And there were a lot of things, there was a lot of concern in the kidney community about the proposed rule here because it seemed as if it was going to be really challenging for both dialysis facilities and nephrology practices to be able to comply with this. So among the things that the provider community thought were positive were the fact that it was silent on the 80% benchmark. And no one's arguing with the fact that we have to have more patients begin at home and more patients begin on transplant. But if people are being judged on being able to achieve that, that would be unfair to the providers. And that's the take of the provider community. The reduced scope, the original rule said that it was going to be 50% of the country. Now it's going to be 30% of the country, and that probably seems a lot more reasonable. I can tell you RPA advocated for 25%, so we kind of considered this an advocacy victory because they came close to what we asked for. A decreased span of bonuses and penalties. At one point, folks who weren't able to achieve the goals were looking at something like 13% penalties, which is a pretty big penalty for a provider. And they scaled that back down. I think that number's down to 10. and the bonuses aren't as high either. But, the whole thing is you could probably drive policy change with a 5% bonus or penalty. So, having 13% seemed pretty high. So they did come down on that a little bit. Aggregation refers to the fact that rather than having every dialysis facility or every nephrologist judged on how they perform in this model, you're able to aggregate, which is to say the dialysis facilities that are working for a particular, in a particular metric for a particular company could pool their numbers rather than report individually. And what this means is that for some dialysis providers, they will have one home dialysis facility in their region and send all their home patients there and focus on that. And that becomes a bit of a center of excellence, but you would be penalizing all the other facilities in that area. But aggregation sort of takes care of that. And also for nephrology, it allows aggregation for nephrologists at the nephrology practice level, not at the individual nephrologist level. And that's better as well. And then there were improved transplant metrics and then this is measurements for how facilities and doctors do and perform, and they made these to be more reasonable and more achievable. So the remaining challenges include the absence of alignment, which is to say a patient could be in the model for their dialysis facility, but not in the model for their nephrologist, or vice versa. CMS did not align that, and that would be problematic, create some kind of goofy incentives. There's no risk adjustment. Risk adjustment refers to if a provider is treating really sick patients, and I know all ESRD patients are really sick, or not, I shouldn't say that, or at risk, but if a provider has a really difficult patient load, there's no adjustment for that. They typically do that, and they're not doing it here. And then limited exclusions. I think the provider community thought there should be more folks that weren't put into the denominator because they wouldn't perform well in the model, but they did not do that. Now, the outlook for this is unclear. It's certainly still on the books, and the Medicare innovation system is all systems go for now. But I've talked to staff there who are aware of what they call as external realities, and I think this is the point of the Biden administration's coming in, and they might want to take a look at this before they proceed with it. Future rulemaking is to occur. CMS said that in their rule on this. It won't necessarily happen yearly, but I think that's a recognition that there are some things that they might have to change. And everybody who's part of the model right now, that is all the providers, all the dialysis facilities, and all the nephrologists, if you're part of the model, you are now. So we can move on to the next slide. Thank you. So that was the mandatory model. There are also voluntary payment models. So practices could, and this is, the KCF refers to nephrology practices, and the KCF is Kidney Care First, and CKCC, oh boy, I'm going to get the acronym wrong. Kidney Care Choices. I'm not going to get that. I'm not even going to try. Look up CKCC if you're interested, or I can look it up later. Anyway, these are voluntary payment models. So this would be for providers who, want to go into this, think they have do care coordination well, and they can get some benefits for this. So the rulemaking per se is over for now. And the way the changes happen now, the way they're announced, is revisions to the participation agreements that Medicare has with the groups that have applied to be in the voluntary payment models. They made some changes recently that are positive from the perspective of nephrology. If the nephrologist provides if the nephrology practice provides 4 visits, they will get reimbursed at the full billed rate for their work, which that was not the case before. And they're going to send money for this straight to the nephrology practice. Previously, it was going to be sent to the entity that was created, and that would be a problem because that's a whole lot of money for a nephrology practice, so that would cause a cash flow problem. And not only that, payment for home dialysis will be set at the 4-visit level, which is a big victory for home dialysis to the extent that there were any disincentives in nephrology payment for home dialysis. It won't be that way in these voluntary models, and that's great news. So soft participation agreements, and when I say soft, I mean non-binding, were due a few weeks ago, and then the binding participation agreements are expected to be required sometime March, maybe April of 2021. So next slide, please. So there are two other rules that came out of the Advancing American Kidney Health Initiative that are a big deal, and these are the ones that we're still waiting on to be finalized. But there was a proposed rule on what they call the conditions for coverage. If you're going to be a Medicare provider providing care, and when I say provider, this is on the facility side, you have to satisfy what's called conditions for coverage in order to be able to provide services to Medicare patients. And the organ procurement organizations, that whole world had not had their conditions for coverage updated for a long time. So this rule would do that. And then there was another bill that expanded reimbursable living organ donation expenses. And both of these rules were published in December of last year. Excuse me. So with regard to the organ procurement organization rule, this would be the first update to the conditions for coverage for OPOs since 2006. And what it does is it intends to increase accountability and the use of incentives in organ collection and transplantation. A lot of people thought organ procurement organizations in terms of regulation were really under-regulated, and it was kind of the Wild West. There was one representative of the patient community who always used to say that no organ procurement organization has ever lost their Medicare contract. Some people argued that point a little bit, said there had been consolidation in contracts. But if no OPO had ever lost their contract, you could argue that, while some organ procurement organizations were performing really well, others might not have been performing nearly as well, and maybe they should have had their contract reviewed, and that never happened. So the way they're going to do that is that there are measures evaluating donation rates and transplantation rates. They're publicly going to announce who the OPOs are in the top 25% benchmark. So they're going to be announcing who the top OPOs are. So that's an incentive for everybody to get better and be in that top 25% and get, have that be publicly announced. And then it establishes 12 months reviews for organ procurement organizations. I think they were not necessarily happening on a 12-month basis, and that would change that. And then moving on to the living organ donation rule, it proposes to increase reimbursable expenses incurred by living organ donors to include lost wages, child care, and elder care expenses incurred by a primary caregiver. I mean, and this is a great thing for the administration to be doing, to try and figure out a way to recognize that there's lost expenses when folks go through the living organ donor process, and this would address that. And again, as I noted, neither rule has been finalized yet, but they're not on the Office of Management and Budget website anymore either. So it could be that the rules could be released imminently. We talked a moment ago about how the Trump administration's trying to get a lot of rules out the door. I would not be surprised if these fall into that bucket. Next slide, please. So talk for a little bit about telehealth. I think I only have the one slide on telehealth, and I'm probably underplaying it because it really has been a big deal this year. But there were sweeping changes that were put in place in the spring. And one of the big things that they did was they eliminated restrictions on what they called originating sites, which is where the patient is. And pretty much what the administration said is the patient could really be anywhere and participate in telehealth. They used to say you had to be in a doctor's office or in a hospital or a community health center. They did not include the patient's home, did not include the dialysis facility, and they're including it now. And then the other thing is they removed all the geographic restrictions. So it used to be that telehealth could only be done in rural areas. Now you can be anywhere. So those are, to me, those were both game changers. As soon as they fixed that and removed the originating site and geographic restrictions, everything changed. So that happened in the spring, but for how long is that going to be the case? Now, the public health emergency, which keeps the telehealth changes in place, is currently in place until mid-January. Actually, I think it's January 21st or 22nd. I don't think there's any expectation that the Biden administration won't renew it. So it will be almost certainly be renewed at least once, and they do it in 90-day intervals. So that would likely put it into April, and I would guess it will happen at least one more time after that. But for now, they're in place until mid-January. There's a lot of support on Capitol Hill for a semi-permanent extension, but it's not universal. There are particularly some Hill Democrats who feel like a lot of the oversight abilities being removed by the waivers that were granted to promote telehealth, and I think they want their oversight ability back. And not only that, it's worth noting that there was a bill passed that allowed the administration, allowed Medicare to make all these changes. And that bill, I believe, only calls for it to be to be allowable as long as there's a public health emergency. And as soon as that ends, their waiver authority ends as well. So there's probably going to be some legislating on this, I would guess, in the next year, but we'll just have to see what happens. Some groups in organized medicine, I used to work for the American College of Physicians, and they were calling for all the telehealth stuff to be in place until the end of 2022, with the idea being this would give an opportunity for people to figure out what worked, what didn't, and figure out what we need to keep in place permanently. So in terms of ongoing concerns in kidney care and telehealth, they still don't allow billing for acute kidney injury home dialysis. This was a really big deal in the first days of the pandemic, because in New York City, for instance, it would have made much more sense to send acute kidney injury patients home and put them on peritoneal dialysis, and that would have been much safer because they wouldn't have been in a hospital setting where they could get COVID. They also don't allow for home dialysis training to be done via telehealth. That seems to be sort of silly. Now, as time goes on, the fact that these haven't been fixed yet makes me think that change in this area is unlikely, but we'll see what happens. And I can tell you, Lori and I were part of a HHS kidney telehealth work group. So RPA and RSN were both part of this that came up with a group of recommendations. It concluded its work in September, but we called for elimination of what I talked about before, the originating site and the geographic restrictions, and it called for a lot of other changes as well. These were recommendations that were made to the secretary. We'll see what happens. Of course, the administration's time is running short. We'll have to see if that would get taken up by the next administration. Next slide, please. So just talk briefly about the 2021 payment rules. These are how physicians get paid, or ambulatory surgical centers where fistulas get paid happen. They came out this summer, and there was great news in the Medicare fee schedule for nephrology because they really increased the value of dialysis codes. These are codes that have been undervalued for a long time, and there was a big victory. And they're also paying primary care doctors, including nephrologists, more for evaluation, what they call evaluation and management codes, but those are your office visit codes. And everybody thought that was fabulous because primary care has always been underpaid in the Medicare fee schedule. But there's something in the Medicare fee schedule called the conversion factor, which is kind of a multiplier through which organized medicine gets a pay raise or a pay cut every year. And the fact that they increased so many things meant the conversion factor took a big cut. And there's been a lot of people, particularly the surgical and procedural societies, that are fighting the conversion factor cut. And this is all playing out as we speak. We'll probably know a lot more about this within about the next month or so. But that could complicate these big increases for nephrology and for primary care. If those increases go through, nephrology will get a 6% increase in reimbursement for services provided to Medicare beneficiaries. And then I only have one bullet on vascular access, and that's that no news is good news. To the extent that there were changes in vascular access reimbursement, and this would be reimbursement for fistulas and for fistulas mostly, hopefully not catheters, but fistulas. To the extent there had been news, it wasn't great news. So the fact that no news is good news because it means that payment rates are going to stay stable and there will be predictability and reimbursement in Medicare for vascular access services. Next slide, please. So I know I said I was going to talk about Medicare Advantage, and I know folks have already heard about this. But the 2021 rule came out in May, the final rule, and Medicare Advantage plans in 2021 will be allowed to enroll all ESRD patients for the first time. Previously, it was only if you already had a Medicare Advantage plan, were already in one when you developed ESRD, and now all ESRD patients can get into Medicare Advantage. And this is due to what they call the 21st Century Cures Act that was passed a couple of years ago. Now, there were a lot of concerns with what happened with the Medicare Advantage rule. It not only reduced payment rates, but it also eliminated what they call time and distance standards. And just for ESRD patients, And what time and distance standards do is they make sure that a patient, no matter what their disease is or what their condition is that they're within, I think it's 30 minutes or 30 miles, something like that, to make sure that you can make it to your provider of care without undue stress. And they eliminated these for ESRD because the thought was that the dialysis companies could just provide home dialysis, and that would take care of any need for time and distance standards. A lot of people in the community were upset about that, and the organization Dialysis Patient Citizens even filed a suit with Medicare over this. The suit is still outstanding, hasn't been resolved yet. I can tell you from the nephrology point of view, there's a concern that Medicare Advantage plans are dropping a lot of nephrologists from their plans. And the example I know of is that 25 of 32 nephrologists in Hawaii were not renewed for 2021. And this becomes its own access issue, of course. You know, it might force people to change who their nephrologist is because if they want to be in their Medicare Advantage plan and the nephrologist isn't part of the plan, that sort of defeats the purpose. So I'm sure you heard much more on that earlier. That's just kind of a snapshot of the things that RPA is concerned about. Next slide, please. So the outlook, what's going on here? So, you know, it's been just absolute chaos in Washington, you know, for the policy, political, and electoral reasons we've talked about already. You know, the first three COVID packages slid through pretty quickly, and they really were impressive regardless of what your politics are. But number 4 has been challenged. I think the thought was it was going to be more likely since the election, but just what I've read in the last couple of days since I did this slide makes me a little more dubious about whether we actually will get a package. And then again, as I noted, we'll have to see whether the president would sign a big stimulus bill. You know, the Biden president-elect group is pushing for COVID relief to happen as soon as possible and to be as big as possible. But we'll see what the dynamics are on that too. And then there's all the other mega issues that have been going on that sort of deplete the oxygen levels. And what I mean by that is all of these things are so exhausting. It's hard for members of Congress to have their attention to be focused on the things they have to do, like a stimulus bill or like a Medicare extenders bill. And for that reason, I think the lame duck is going to be really wild. Again, I think the makeup of the next Congress is different than what people thought it was going to be, particularly House Democrats. I think they have a lot of reason to, House Republicans are feeling a lot more emboldened than they would have been before the election. Although Nancy Pelosi, for her part, is still saying we still control the House and that's all I care about. So, you know, we'll have to see what happens with this Medicare extenders package. It currently is scheduled to run out on December 11th. So that would be the deadline to get it extended. And as noted, everybody and their brother in the kidney community in DC is trying to get the immunosuppressive drug coverage package to be included in the Medicare package when it gets renewed. Next slide, please. And then as noted, you know, what happened in telehealth was more than impressive, really unbelievable. Again, 10 years worth of policy making in 6 weeks, but we'll have to see what happens. Again, you know, the waiver authority to HHS broadly would have to be renewed, and then we'll have to see what sort of provisions and what sort of policies they enacted would continue. I'd say all's quiet on the kidney payment model front for now. Although it'll be interesting to see what happens under a potential Biden administration. I would think that a Democratic administration would be less likely to automatically begin to undo things under a Republican that got established under a Republican administration, mainly because Democrats believe in regulating more than Republicans do. So for that reason, you think it would be more likely that, for instance, all the kidney payment models would continue sailing and not be interrupted, although we'll have to see on that. It might be that the Biden administration will say we want to take a look at all these things, and maybe they'll extend questions for a little while after that. So it's and that kind of leads right into the next bullet. It's unclear what the impact of the transition to the pending Biden administration will have on all of these things. Of course, the Biden administration is going to be focusing on Obamacare, the Affordable Care Act, and making sure that's as robust as possible. They will certainly get pushback to the extent that they have to try to do that legislatively, but there are a lot of regulatory tools at an administration's disposal that they can do to make changes. So, and then the last bullet is something I already referred to. Important to remember, Democrats are generally more supportive of regulatory activity and Republicans less so. I think that's my last slide. I think the next slide is just my contact information. I will never, ever, ever, ever encourage anyone to get on Twitter. However, if you happen to already be there and are interested in health policy stuff, I tweet about it occasionally in real time. So follow me, follow RPA Nephrology, and always feel free to shoot me an email. And if I can get you an answer, I will be happy to do so. And Lori, I don't know if I left much time for questions. I guess we got 13 minutes. Yeah.
Yes.
Okay. Happy to field questions.
Okay, terrific. Let's see. Actually, Cher, is your speaker working?
I hope so.
Oh, yay.
Ah.
I'm going to let you
Listen to
field
you,
the
Cher.
questions.
Praise the Lord and pass the liquor.
I've been listening to your wonderful presentation, and it's so informative, very informative. I appreciate everything that you shared with us. And actually, we have a few questions in Q&A, and we have a few minutes. So if you wouldn't mind entertaining some of those, I'll read them to you. Okay, I don't know that I completely understand this question, but maybe once we read it out loud, we'll be able to understand the gist of the question. But it says, is there any advocacy about rural dialysis clinic access, or about the ability of clinics to refuse rural patients for reasons other than patient aggression / payment issues?
Well, I will tell you, rural healthcare has some really strong advocates in Congress. And I think CMS does their best to make sure that rural patients have access to the care they need. Now, this question sounds like it drills down a little deeper than that, and I think it goes deeper than my knowledge base. I mean, whether there's advocacy for it, that would be something that the patient organizations would take up, and I'm sure Lori tries to do that. I'm not sure if I'm answering the question or if I even know the guts of it.
I think I know what Amber's trying to say, because, you just mentioned about Hawaii and some of the nephrologists, and if you get into a certain plan, like in California, you're Medi-Medi, you are already in managed care. And if you have access to a nephrologist or a limited network, and then if you're in a rural area, there's less choices. And I've heard of some situations when patients don't show up to dialysis because they're saying refuse rural patients for reason other than patient aggression or payment issues. If you don't show up for treatment, the facility is under quality measures. So they won't continue to treat. I mean, they don't want to just leave the chair open. After a while, if you don't show up, they have a way to be able to, try to get you another. I don't know exactly what they do, but I've heard that they can, basically discharge you if you don't show up for regular treatments. And it's an issue because facilities are being measured on quality, and you're just not going to have any quality if you don't show up for treatment.
Right.
I don't know. I work comment on that.
I work for nephrologists, and not that they always wear the white hat, but I think mostly they do. And so I think nephrologists do their best to make sure that all of their patients, no matter where they're located, get the care they need. And I'm not trying to throw the dialysis companies under their facilities under the bus, but there is a little more of a, shareholder concern there. And that might be a reason why they would be quicker to do that. That doesn't make it right. I'm just trying to figure out why that would occur. In terms of patient advocacy, I will tell you, we talked about the time and distance standards piece a moment ago, and I'm quite sure you heard about that already today. CMS issued a a list of, I think it was a payment, the technical correction or some sort of a list about payment rates. And interestingly, they included language in there about time and distance and how they didn't, if I'm remembering this correctly, didn't intend for time and distance to be interpreted in a way that eliminated care for patients. So I think CMS knows they stepped in it a little bit and are trying to send out a message to the insurance companies and to the dialysis facilities, although this is not on the dialysis facilities, this is on the Medicare Advantage plans, that you better make sure you take care of your patients, and if they don't choose home, you better make sure there's a way for them to get care. It'll be interesting to see how that plays out, but that's there now.
And then also there's the ESRD networks that advocate for people. So if you have any problems, you can go, if you'll put that in the chat, esrdnetworks.org. There's 18 of them across the country, and you can in turn find which one is yours, and they can help advocate for you. So,
and Lori, thank you for remembering that. Yeah, I forget about the ESRD networks, but that's what they're there to do.
That's what they're paid. They get 50 cents per dialysis treatment. So every Medicare payment, the networks are paid 50 cents per treatment. So they have funding for that. So that's what they're there for, to help oversee the quality and access to care for people who have Medicare, which is about over 90% of people.
Well, and it's funny over the years, and I might be speaking out of turn here a little bit, but among us friends, what the heck? There's been times when the networks wanted to do stuff and the dialysis facilities would say, oh, we don't need them to do it. We do it better than they do. And it's like, well, maybe it's good to have a third party do it rather than the companies. Maybe the government should actually have some sort of oversight for this or that. So anyway.
And I think there's one more question, Sharon, and then we'll move on to our next speaker.
There is. Connie has asked, we've been hearing that certain plans won't cover nephrologists, but this is the first time I've heard of the number 25 out of 32 nephrologists denied payment coverage in 2021. What will our patients do here in Hawaii?
Great question, and I wish I had a better answer. Of course, you can choose not to be in a Medicare Advantage plan if you're not in one already. And that's probably the best path if you're not in one already. And that's a shame because Medicare Advantage plans, I guess, are all over the place. I think some of them offer great stuff that people want to take advantage of. But I also know a lot of nephrologists, like Medicare Advantage plans in our geography are horrible. So if you're not in a Medicare Advantage plan, there's no requirements that you go to one. It might be that your dialysis facility or your nephrologist thinks it would be a good idea, but the patients really got to make their own call. You should really look before you leap. Now, if you're already in one, perhaps you'll have good fortune and your nephrologist will be one of those. But if not, I'm not sure what to say. I'm sort of surprised this didn't become a bigger issue. I know the kidney community, including RSN and RPA and the dialysis companies, all fought this when the rule came out, but CMS proceeded they finalized the rule with this language in it. So, I would guess to say that this is going to be an advocacy point. I know you're asking for advice on what to do now, and I'm not giving any because I'm not sure what to say other than the fact that if you're not in a Medicare Advantage plan and you have any questions, don't go into one because your care will be at least what it's always been up to that point. Lori, am I being fair there? Sorry, I don't want to.
No, you're doing great.
Okay.
Well, I'm going to turn you back to Cher, and I'm spotlighting Cher now because I'm learning how to do all this. And I think we're good. Thanks, Rob. I really appreciate it.
No problem. It's been great. Thank you all for the invitation.
And a shout out to our corporate mission partners for making this happen.